submassive PE, and the critical PE patient. All right, thank you so much, Haney.
Thank you. Have you ever had a patient come in with a PE? Yeah, we've all had that. Have you ever had a patient come in with a really big PE where their RV is kind of sluggish and not working well, but their pressure's okay? What do you do with that person? That's a really hard thing to know. I don't think there's guidelines that support us to tell us what we should do. But we're going to go through all of that today and a little bit more. And I want to talk to you about the patient with the sick RV, specifically from a pulmonary embolism point of view. So as Sal said, my name is Haney Mallemat. I'm from Cooper University in Camden, New Jersey. And I want to give you, thanks one guy. All right. All right. 3 things that you need to know for this lecture. The first thing is, we can't talk about managing the sick PE patient unless you identify the patient with the PE, with a sick RV. The second thing is we're going to go into a little bit about thrombolytics and some adjunctive therapies. And then finally, we're going to talk about the hemodynamic support for those patients as we have them. So let's start off talking about the RV. Now, I apologize if you're not an ultrasound person, but I think this is something that we all should start getting familiar with because I don't believe ultrasound is a physician thing. I don't believe it's a cardiology thing. I think it's a thing that with training, everyone should know. And medical students now and nursing students are starting to use ultrasounds on their shifts. Instead of getting the stethoscope at graduation, they're getting these portable ultrasound machines. So you got to be able to keep up with these youngins. So I think that if you don't know, this will be a little introduction and hopefully motivation to learn more. Regardless, whenever you ask what the squeeze of the heart is, the RV doesn't get any respect. It doesn't get any respect. It's like Rodney Dangerfield. All right? Because if I showed you this and say, what's the squeeze? I know every single one of you is looking right there at the left ventricle. And that's really unfair to the RV. You should be ashamed of yourselves. You know how else I know the RV doesn't get any respect? Because every shift I work with residents or even fellow attendings that say, what do you think about that right ventricle? This is exactly the look that I get. Every time. But the RV is an incredibly important structure. It is not just a vein that feeds the left ventricle. It is actually a structure that has a very unique shape to it, as you see here in blue. It's a horseshoe shaped, very thin-walled. And if you don't treat the RV right, the RV will screw you. So you got to treat your RV with a little bit of respect, and we'll talk about that. So let's talk about some of the views you can use for your RV. These are just 2 views. There are many views you can use to get there. But we talked about the parasternal long axis view. If you rotate it 90 degrees, you can get to your parasternal short axis view, and at the level of the mitral valve, this is what you should see. You see the LV right there in the center with that fish mouth view. That's your mitral valve opening and closing. And to the left of that, you see your crescent-shaped right ventricle. And what I want you to notice here is not so much the size of the ventricle, but the septum. The septum in systole and diastole is concave with respect to the left ventricle. That is normal. However, you've heard of this D-shaped septum before, and that's what you see over here. Here you see septal flattening during systole, and that's consistent with a high pressure within that RV, and this person has pulmonary hypertension with a new PE on top of that, and you can actually see just how big that RV is. We can also do the apical 4-chamber view, and we've already seen this a few times with TE and just a moment ago, but here's a really nice representation of the RV and the LV right next to each other, and this is how we're going to assess size. Now normally the RV should be 2/3 the size of the LV. So it should fit within the space of the LV, and that's how you know it's normal sized. When you start to have mild dilation of your RV, we're talking about greater than 2/3, but less than 1:1 of your RV to LV ratio. And then when we're talking about RV dilation true, like we're talking about with submassive PEs and massive PEs, we're talking about a 1:1 ratio where they look exactly the same in size. And then when you have severe dilation, that previous one being moderate dilation, when you have severe dilation, your RV is bigger than your LV. So it's not enough to just assess the size, you need to assess the function. And the LV, we all know how to do it, we do it on a daily basis. There's just something inherent in our brains that when we see an LV squeezing, we know whether or not it's good or bad. But the RV is a little bit different. The RV is actually much simpler in the way we assess it because it works only in one dimension. It works like an accordion, if you will. It works by contracting from the base all the way up to the apex. So if you can evaluate this movement in one plane, you should be able to evaluate the systolic function of the RV. And I don't want to belabor you with terms, but I do want to teach you a cool term that you can alienate anyone else in your department and sound really smart and academic, and that is TAPSE. Don't even have to remember what it stands for. Just drop TAPSE, and they'll be like, that person knows what they're talking about. TAPSE stands for tricuspid annular plane systolic excursion, and that is just a super nerdy way of saying how much is that lateral portion of that tricuspid valve annulus moving up and down. Because again, it works in a longitudinal fashion. So the more it moves, the better the systolic function is. The less it moves, the less the systolic function. And normally if you want to remember numbers, although I'm a big fan of using your eyeballs, if you want to remember numbers, the movement 16 millimeters or more is consistent with normal RV function. You could do things like M mode, and we don't have to go into that today. It's not really a talk on the right ventricle per se, but you can do it that way. But again, you can eyeball it, because if I show you this TAPSE over here, you can see that that lateral annulus is not moving much. And if you measure it out, it's only moving 7 millimeters. But you could just look at that. That RV is big. The TAPSE is not very much. So they have dilation and they have systolic dysfunction. So by all means, drop TAPSE all over the place. McConnell sign. It's one of those signs that we've previously thought was pathognomonic for pulmonary embolism. Now, the truth is that McConnell sign, which is basal hypokinesis with apical sparing, as you see here, in the right clinical context could be pathognomonic for a PE. However, when you look at the data and just take any person's echo that has McConnell sign, it seems like it's 50-50 between someone who has a large PE or someone who has a right ventricular MI. And I'll even defer to my cardiology colleague in the back. What do you think? Is that right, or am I off a bit? Okay. And by all means, I have given him permission to heckle me, to interrupt, and to correct me at any point. I mean that sincerely. So yes, right clinical context, McConnell sign is a PE, but don't think that if you just did a random ultrasound on somebody and you see this, that this is a PE. Think further, could this be a right ventricular MI in someone who is not very obvious? The other thing is that if you're doing ultrasound, if you're in a panic, sometimes you can look down and forget which way your dot's going and say, you know, that RV is big, or maybe I have the probe reversed and I'm looking at the LV. It can be a hard thing to do. So I want to give you 3 tricks on determining whether or not that big structure that's in front of you is in fact the RV, or did you have the probe marker reversed. The first thing is look for the moderator band. The moderator band is a structure right here which is exclusive to the right ventricle. It carries the right bundle, and the left ventricle doesn't have a moderator band. So if you see something with a moderator band, even if it's really big, think RV. The left ventricle also doesn't have trabecula. And as RVs dilate over time with chronic pulmonary pressures or pulmonary hypertension, you'll see the muscle gets bigger and the trabecula gets bigger as well. These are like little finger-like projections that extend out into the ventricle. The last thing is that when you're doing your apical 4-chamber view, if you tilt the probe a little bit, you might be able to get, that's what's called the 5th chamber view. This is the left ventricular outflow tract, something exclusive to the left ventricle. So hopefully these tips can give you a little better orientation. When you have somebody who's really big and there's a lot of things happening in the department, you can look down and say confidently that that's the RV, or maybe the probe was just reversed in the first place. Nothing worse than giving TPA to someone who has a normal RV and the probe was just reversed. The next question becomes, we have so many patients who are sick with chronic pulmonary hypertension. How on earth are you going to know whether or not someone's RV that's big is an acute process, an acute PE, or is this a chronic process that's been happening all the time? And for this, the best approach is to use the subxiphoid view. And what you're going to do with the subxiphoid view is you're going to look at the free wall of the right ventricle, because pressures over time will cause RV hypertrophy of that free wall. An acute PE, for someone who had a normal RV and normal pulmonary pressures, will have dilation, but the wall should be the same size. The normal size of the free wall of the RV is 5 millimeters measured during diastole. And then if you compare that to somebody who has a big RV, this person has a big right ventricle, but then you look at the free wall, not measuring the trabecula, you see that that person's RV free wall is thickened. So this person has chronic pulmonary hypertension, chronic RV dilation. Now, it doesn't mean they couldn't have a new PE on top of that, but it's really beyond the scope of this discussion. And it is a very difficult thing to know whether or not someone has an acute versus an acute on chronic process without doing a CT scan. There are ways you can do it with echo, but we won't go into it. So let's get into the meat of the matter, and that's how do you manage the person who has a pulmonary embolism? Now, you'll know that there are 3 big boxes we put patients into when they have PE. We have the non-massive PEs, we have the submassive PEs, and we have the massive PEs. The submassive PEs, we know how to handle those. Those are easy. Those are the people that come in from a long trip, or they're recently immobilized, or they have cancer, they're tachycardic, they're hypoxic, but their blood pressure is normal. You send a troponin on them, their troponin is normal. There's no RV strain when you do the ultrasound. There's no hemodynamic load on that RV. They just have some segmental PEs creating a VQ mismatch. These patients get heparinized and admitted. In some places, they're sending people home on Lovenox in some advanced centers. Massive PEs are the other half of the coin. These are people who come in, whose RVs are big and dilated, but they also have hemodynamic consequences. They're malperfused, they're shocky, maybe they're in cardiac arrest. So let's take a look at this group now and talk about how we're going to manage these people. Now, the guidelines suggest giving thrombolytics to these patients exclusively. That's how you manage someone who has a massive PE. But the question becomes, what dose do you use? Now, if you look at the trials that have looked at treating massive PEs with full-dose anticoagulation, they all improve mortality. The problem is they increase the risk of bleeding. Intracranial bleeds, massive GI bleeds, and even minor bleeds. So it's a risk-benefit ratio. So the next question becomes, how about if we used half-dose thrombolytics for patients who have a massive PE? Would that help? And there's one study of about 118 patients that compared them head-to-head and found that you got the same amount of reduction in clot burden with less bleeding in the half-dose. There was a trial called the PIAPET trial from 2016 that looked at 23 patients, not a huge amount, but 23 patients who had cardiac arrest and evidence of a massive PE that got half-dose, 50 milligrams of TPA, and 22 of those patients got return of spontaneous circulation. None of those patients had major bleeding complications. So yes, TPA for this group. The optimal dose, not really sure. And something I just want to put out there that some places will do is that you can always start off with a lower dose of thrombolytic, and you can always give more if you don't get better hemodynamic response. It's just harder to take that TPA away if you mess up. So just keep that in mind. But that category, most of us are pretty comfortable with. It's this middle category, the submassive PEs that, geez, the guidelines won't help us out. No one helps us out. In fact, I work on both sides of the coin, but sometimes when I call as an emergency medicine doc upstairs and I say, hey, listen, this person's going to be yours. Can we discuss a little bit if you want to give TPA for this person? They're like, oh, no, it's your patient, so we'll see him when you decide, and the patient gets up here. I'm like, thanks a lot. I'm never taking your sign out in the ICU. But these are tricky patients. So let's talk a little bit about these patients. Now, submassive PE, those are people that have evidence of RV dilation. If you look down at the RV and it's greater than 1 to the size of the LV, that's evidence. New RV strain, a troponin leak, BNP, anything that indicates that there's RV strain is suggestive that there is a submassive PE with normal blood pressure. So the person has a normal systolic blood pressure greater than 90, no evidence of end organ dysfunction, and they have an RV that's big. That is a submassive group, and it's a challenge. Now, it used to be a little bit more challenging because what we used to think is, well, I have this person here, and I definitely want to manage their short-term hemodynamic decompensation. I definitely want to do that. I don't want them to code on me. I don't want them to code on the floor. So that would be a reason to use thrombolytic agents. But long-term, I don't want that person to go out and have pulmonary hypertension in their future or have more clots, which we thought was the case. But they followed a group of patients from the PITHO trial, which was a trial where they used thrombolytics in submassive PEs, and they followed them out. And they found that there was no mortality difference between the group that got heparin and TPA. They found no evidence long-term harm for those patients, for those that, repeated PEs. So it seems like the short term is really all we're managing here hemodynamically. The long-term stuff doesn't seem to matter if you give them TPA or not. So that's good news. Now all we have to focus on is the decision we're making in that short term. So we have 3 options medically for patients who have this submassive PE. We can give them full-dose thrombolytics, we can give them half-dose thrombolytics, or we can say, no thrombolytics for this person, let's just put them on heparin. And let's look at the evidence. It's all poor, but let's look at the evidence that we have. So certainly, giving somebody full-dose TPA will reduce their short-term mortality, but at the expense of increased bleeding risk. There's been a meta-analysis, there's never been a head-to-head trial, meta-analysis of full dose versus half dose that has shown that there's a reduction in clot burden when patients get full dose and half dose, but in the patients that got half dose, there was less bleeding. So maybe half dose is all we need for those patients. Or I should say reduced dose. Because the question now becomes, what's the best dose? Is it really half dose? Is it less? Again, a little less clear. There's a trial called the Mallemat trial a couple of years ago. They took patients and they gave them a dose, submassive PE, 0.5 milligrams per kilogram, but not to exceed 50 milligrams. And if you look at the data, most patients actually got between 30 and 40 milligrams. And they found that their patients had lower mortalities, less reduction in clot burden, and no bleeding episodes. So maybe lower dose TPA would be okay for this population of patients. Let's ask the question, well, maybe we don't need TPA at all. Maybe we can just use heparin. No head-to-head studies here. Again, just meta-analysis looking at full dose TPA versus heparins. And unfortunately, what it shows is that if you just use heparins for your patients, more of those patients will have hemodynamic collapse versus those that got the thrombolytics. So it appears that just using heparin alone is not going to be such a good idea. Now, listen, I'm not trying to say don't be afraid of TPA. We're all afraid of TPA. We actually had a patient who had submassive PE who was really looking sick, who we gave TPA to, and no joke, a couple drops of TPA when the nurse was looking at it landed on my arm. I must have looked at my arm like 10 times a shift to make sure my arm wasn't bleeding and it wasn't about to fall off. I get it. I get it. But let's look at the data. Let's see how bad TPA really is. When you look at half-dose TPA and you compare it to heparin, in the studies that we have, the bleeding risk between the two is the same, about 0.2%. So the question becomes, if the bleeding risk is the same and the hemodynamic benefit is there for TPA, why aren't we just doing TPA? Let's not be afraid of TPA for the person who really needs it. Now, for the person who is older, above 65, for the person who has an absolute contraindication to get thrombolytics, there are other therapies available. There are catheter-based therapies, and there have been several that have been around over the years. The one I'm going to talk about is the one that seems to have the best data moving forward, and that's the ECOS catheter. And essentially what they do is they go in and they put a wire through the clot, and they put this catheter that has ultrasonic capabilities while dripping in very low doses of TPA on the order of 1 milligram per hour, and this breaks up the clot. Now, full disclosure, these studies are all funded by, oh, guess who? Oh, the ECOS catheter people. So you have to take everything with a grain of salt. There's only one study that's compared the TPA invasively with heparin. That's the Ultima trial. It showed a reduction in clot burden as compared to heparin, so that's good. The Seattle 2 trial was only a single center study where they used 1 milligram per hour for 24 hours, and that showed a reduction in clot burden. And then finally, the newest study, the Optimize trial, is looking at much lower doses of TPA over a short amount of time. In one of the arms was as low as 2 hours and found reduction of clot. But again, this was never compared against TPA going systemically, the same dose going in a peripheral IV. So we don't know whether or not it's the TPA or the catheter that's making a benefit. I can tell you in our center, this is something that we do routinely, and the outcomes, as per the data that's unpublished, seem to be very, very good. So if you have somebody that is not a candidate for systemic thrombolysis, think about having a catheter or transferring your patients. Now, this is really cool. This is really awesome. How about sending your patients to surgery for thrombectomy? Check this out. Philippe Turan sent this video, and this is an intraoperative view of a thrombectomy. This is like a magician with that handkerchief coming out of your pocket. It's like, when is this thing going to end? It's amazing. This has to be tempered with the fact that this is dependent on your institution. You have to have surgeons who are able to do this. This has to be a very proximal clot. The distal clots that are caused and that are diffuse and spread out, that are causing RV dilation, they may not be amenable to this. It has to be a clot that they can grab onto. And even after you pull out this clot, there's still a clot that's left behind there. So just something to consider. Now the other thing is, we put these patients into 3 boxes, non-massive, submassive, and massive. But maybe, just maybe, that submassive group should be spread out. Maybe it's not a group, maybe it's a spectrum of patients. The submassive low-risk patient and the submassive high-risk patient. And you've seen these patients before. The person with the submassive low risk, they get transferred to my ICU because someone looked at their ultrasound, got freaked out, they sent them, and they're reading like the Wall Street Journal. And it's like, doc, when am I going home? Very soon. Well, first you're going to the floor, and then you're going home. Maybe these patients, all they need is heparin, Maybe that's all they need in monitoring. The person who is submassive high risk, they're someone whose systolic blood pressure is normal, but every time you move them to the stretcher, or every time they move, they desat, they hemodynamically compensate, and then they have to build up again. Maybe that's a different person, even though they fit the same mold, they fit the same criteria, they might be two different patients and should be treated differently. Maybe that person needs to be aggressively treated with TPA. The other thing to consider is maybe that person who's just chilling there, reading the Wall Street Journal, maybe we should look a little harder to make sure they don't have other clots that are waiting to break off and cause them further harm. Maybe they have a big clot burden in their femoral veins. Maybe that person, you take them a little bit more seriously. Maybe they don't just get heparin. Maybe they do get TPA because that next clot might be the end of them. Maybe you do another ultrasound and you see this. That clot that's just waiting for that right moment to get to that pulmonary circulation. Maybe this person's treated a little bit differently. So it sounds like a lot. It sounds like a lot for us to make as a decision in the ED as a single provider, or even looking over at your buddy at the next computer being like, what do you think? That's why many hospitals have these things called PE response teams, these PERT teams. Because I personally believe this is not a decision that any one physician should make. I don't believe I should be making that decision by myself in the ED. I don't think I should be making that decision by myself up in the ICU, because I have hematologists, I have vascular doctors, I have CT surgeons, I have interventional radiologists and cardiologists. I have other people that can help me make this decision, and that's what they're doing in some institutions, because every patient is different, and every patient has a different hemodynamic baseline. When these patients come in, they get everyone on the phone, they discuss the case, and everyone makes a multidisciplinary decision on what they're going to do for that patient. And this is good for risk management, because if something does happen with that patient, at least as a group, they've made this decision. It wasn't one physician who happened to read a meta-analysis the previous day and thought that that would be a good idea. So just something to keep in mind. If you're in a center that takes a lot of these patients and you have to manage them, why not get the experts on the phone and discuss it as a group? And of course, you being the emergency medicine doctors and intensivists should also be part of that decision making. So let's just finish up talking about the hemodynamic support while your PE response team is figuring things out, or while you're waiting for TPA to come for pharmacy, about the patients who are most high risk. These are the patients with submassive, high-risk patients, or the massive PE. We have to support that person until we make a decision or we get that therapy on board. Now, the RV, like I said, is a very particular structure. It doesn't like a lot of insults. I guess it's like me, you know? I'm very like soft-skinned, so, you know. But the RV doesn't like to be insulted. And so what I want to show you is this thing called the RV death spiral. When you have somebody who has a massive or really high pulmonary clot load, high-risk submassive PE, what happens is the pulmonary vasculature has a high afterload. It vasoconstricts. And what happens is you get RV dilation. And as that RV dilates, it gets less coronary perfusion. The coronaries don't perfuse that myocardium as well, and so you get cardiac ischemia, which leads to a reduction in cardiac output. And there's less filling of the LV and less cardiac output. There's less mean arterial pressure, and if there's less mean arterial pressure, guess what? Your coronary pressures go down, and if your coronary pressures go down, you have more myocardial ischemia, you have more cardiogenic shock, and then ultimately, you die. So this is the spiral, and what we have to do is we have to break that spiral as we're managing our patients. So how are we going to do that? When you're managing these patients, you have to think about supporting two things. You have to think about the right ventricle, and you have to think about avoiding hypotension. Now, very briefly, for the right ventricle, you have to optimize the preload. Now again, the RV doesn't like a lot of stress, and it can't handle volume. So if you have somebody whose RV is big and they're hypotensive, giving them liters and liters of fluid is not going to be helpful to them. In fact, it will harm them. So if you think the person's volume down, give them a 250 cc bolus and see what happens. If they get better, well then give them another 250 cc bolus. But if they don't do anything, I would suggest abandoning fluids altogether, because a big RV cannot handle volume very well at all. Think about getting ionotropes on early. Think about things like dobutamine, milrinone, low-dose epinephrine, whatever you like as your ionotrope, have that ready and start it early. Get that RV pumping and squeezing back again to improve systemic perfusion. We want to open up the pulmonary artery vasculature. That clot in itself, because of all the thromboxanes and all that nerdy stuff from medical school, actually causes more vasoconstriction. It's not necessarily the clot burden that decreases blood flow to the left ventricle. It's also vasoconstriction as a reaction to that clot. So we have to force open that pulmonary artery. We can do that with things like inhaled nitric oxide or ibupropanol all agents that will promote circulation from the RV to the LV. You want to be sure that you minimize how much hypoxia your patients have. Hypoxia is going to make pulmonary vasoconstriction worse. And hypercarbia, letting them retain too much, is also going to make vasoconstriction worse. So you just want all your numbers to be normal. And then we want to minimize hypotension for our patients. The way we minimize hypotension is avoiding intubation. Intubation can cause hypotension, and any anesthesiologist you talk to will have a healthy respect for the person with severe pulmonary hypertension, and they won't want to intubate those patients until the very, very end. We don't always have the luxury of making that decision, but just have a healthy respect for the person who doesn't need to be intubated right away. Wait till the last possible moment for someone who's a big bad PE, because that person can crash and die. If you do intubate them, use smaller doses of your induction agents. Really low dose of etomidate, really low dose of ketamine, and full dose paralytic for those patients. I get vasopressors up, run them peripherally, norepinephrine, running while I'm doing the intubation if I need to. And use push dose pressors as you need. If you have the ability to get an A-line placed, monitor what the blood pressure is second by second. If you don't have the ability for an A-line, again, I never want to sound ivory towerish, use your non-invasive cuff, but be sure that you have it cycled every minute or two. Because usually what happens is that room that the patient's in now had someone with like ankle pain before, and so they were cycling the blood pressure every 30 minutes. You need to cycle that blood pressure frequently because these patients will change on you very quickly, and you want to know when they drop their pressure. And then finally, if you intubate these patients, be very cognizant of using as little positive pressure as possible. Low peeps, low tidal volumes, because positive pressure, again, is going to hurt this RV. So we went through 3 general things today. We went through identifying the person who maybe has a sick RV. We're trying to identify the person who has a submassive or a massive PE. We talked about the controversies and the data that we have, albeit little, for using full dose, half dose, and no dose. We talked about catheters. We talked about surgical embolectomies. And then finally, we talked about how to manage that person who has some RV dysfunction while you're waiting for your therapies to kick in or while you're waiting for a decision to be made. I want to thank all of you for your attention today. I want to thank Sal for inviting me here. You guys have been a wonderful audience, and I'll still be here for a little bit if there are any questions, but I did want to take this opportunity to thank you for the invitation, and I hope you enjoy the rest of your conference. Thank you.